Thank you, Dr. Gray. I just am amazed. And I think Dr. Gray epitomizes taking science and turning it into compassion and working with our patients. That was just amazing. We'd like to take a moment before we go to our next lecture to recognize our sponsors for today's breakfast. Many of us have gone to conferences and had a continental breakfast that was underwhelming, I'm sure. But the breakfast today has been fantastic. There's even 2 lines, and each one has different offerings. I'm not sure if we're supposed to go through both, but they were good. But if we could ask anybody from Country Hills Eye Center, and in particular, to stand up, and then in particular, members of the Douglas and Shelley Felt Foundation, Family Foundation. And I apologize, there were many more here initially, and we want to thank them for sponsoring our breakfast today and for being long-term sponsors of our society. Thank you so much. Our next speaker is Dr. Katherine Hayes. She is a pediatric and adolescent gynecologist associated with Primary Children's and the University of Utah. As I read her bio, her education and training has taken her from the northern border of our country to the southern border to the eastern seaboard and now here in the west. And I don't know if she's going to talk about that at all, but she also demands my respect as a previous member of the United States Air Force. So we'd like to welcome Dr. Hayes to the society.
Thank you for that introduction. I was not going to talk about where I've been, but I originally grew up in Wisconsin. I joined the Air Force to go through medical school and trained in San Antonio. I actually then served in Germany for 3 years, came back to the United States to San Antonio for 1 more year, did fellowship in Boston, and now I'm lucky enough to live in the best place in the United States, out here in the West. We really love it here. So, let's see. I have no disclosures. We're going to just talk about a kind of rapid-fire pediatric gynecology introduction today. So I like to just introduce it because a lot of people don't even know that this is a specialty that exists. So this is a specialty that was kind of born out of multiple different people trying to kind of take care of these kiddos. We do full-range gynecologic care for children ages 0 to 18, and with some exceptions up to 21, 22. We provide both medical and surgical care. We do not do obstetrical care. So as you note, I'm a gynecologist. I have gotten rid of my OB practice, although I do miss that part of my practice. And then we participate in multidisciplinary clinics at the Children's Hospital. So I participate with our colorectal surgeon and urologist in our complex anal rectal malformations clinic. We have a differences in sex development clinic that includes urology, endocrinology, genetics, and psychology. And then we also have a combined hematology and gynecology clinic to take care of girls with bleeding and clotting disorders. So I'm going to kind of do this presentation in like a pearls format. So we'll talk about, I think, about 4 pearls today, and I'll try to leave a little bit of time for questions at the end as well. So the first pearl is about yeast infections in small people. So the premise is that prepubertal children who are out of diapers must have a yeast infection when they complain of vulvar symptoms. The reality is that prepubertal children who are out of diapers rarely have yeast infections. So common complaints that these kiddos come in, so I don't know how many of you are pediatricians here or family practice docs, but these kids come in complaining of redness, itching, burning, pain, it feels weird, it looks funny. I think the most important question is first to kind of clarify who is bothered by the symptoms. Is it child or is it parents? Because lots of parents are very kind of vulvar hyper aware in these kind of 2 to 4-year-old set. Ask about how they are stooling. Are they going every day? What's their Bristol stool type? Are they having pain? Do they have pain with urination? Has there been any bleeding? What have you tried? What kind of hygiene are you doing? Have you had any recent like soap changes or detergent changes? Is this child toilet trained? Are they wiping by themselves? Is someone helping them wipe? Are you using wet wipes? what other activities do these girls participate in? Are they swimming, dancing, doing gymnastics, wearing like leotards or wet synthetic clothes? We always ask if they put anything in their vagina. You know, kids like to put things in orifices, right? Like they put it in their nose, they put it in their ears. The vagina is no exception. They also try to put things there. And then obviously we want to rule out abuse. So what contributes to these complaints for these kiddos is that they have low estrogen levels, which I always have to reassure parents is normal. I go, your daughter's estrogen levels are low. And they're like, oh no. And I was like, no, that's normal. They haven't gone through puberty yet. So they have a much higher pH than someone who's post-puberty at 6.5 to 7.5. They don't have any hair, obviously, and no fat pads in their labia. Their vagina and anus are actually fairly close together. They are trying to be independent. You know, we all know that 3-year-old set where they're like, I can do it myself, leave me alone, I don't want your help. And so that obviously also contributes. And then there's a lot of external irritants. These irritants are things like bubble baths, bath bombs, wearing tights and leggings and leotards and swimsuits, using dryer sheets, putting fabric softener in the wash. Baby wipes are actually super irritating, even those like wet wipes that are supposed to be kind of 98% water. They all have a lot of preservatives in them so that they don't get moldy in the package, and those are really irritating to the vulva. And then we kind of talked about clothing choices. So I think this slide really nicely lays out like yeast versus non-specific vulvovaginitis. So we rarely see yeast once kids are out of diapers. And if we do, in fact, find yeast, we're really worried about the patient being immunocompromised. And so we need to kind of do a further workup for that as well. You know, do they have diabetes? Do they have HIV? Do they have, a cancer that's being treated, whatever. And we kind of talked about that vaginal pH is really hostile to yeast. So non-specific vulvovaginitis, about 25 to 75% of our complaints are going to be this kind of non-specific, really related to hygiene and clothing choices and things like that. So we talk about making sure kids are wiping front to back. When they're at home, there's a lot of vaginal trapping. Well, when they're anywhere, there's a lot of vaginal trapping that can happen. Little girls and big girls like to sit with their knees together on the toilet, and so we talk about kind of opening those knees up. And so a good way that they can kind of work on that at home is we talk about like sitting on the toilet like you're riding a horse. So actually taking your pants and underwear all the way off, turning around backwards and facing the tank of the toilet, because that forces their legs apart and forces them to sit up straight, which causes the urine to go straight down into the toilet, rather than when their knees are together. That urine can kind of dribble into the vagina, and you can get vaginal trapping of that urine that then leaks out over time and causes irritation to the skin. We talk about using ice packs or witch hazel, which can be soothing, getting out of those tight swimsuits and leotards and all those things and getting into loose clothing, sleeping with no underwear, sleeping in a nightgown, doing plain water baths or a shower, getting rid of bubble baths and bath bombs, using bland topical emollients, things like Vaseline or Aquaphor or coconut oil, getting rid of those wet wipes. And some parents will be like, but I just bought a Costco-sized pack of wet wipes. Well, if you're going to use them, rinse them out first. So you don't have to throw them away, but rinse them out under the sink to get as much of that chemical irritant out before you use them. And then actually taking their underwear and doing a separate load of laundry with no dryer sheets, no fabric softener, making sure your detergent doesn't have dyes, and doing an extra rinse cycle, because some girls really are that sensitive. You can also, if they're complaining, especially of itching at night, consider treating for pinworm empirically, and we recommend 2 courses of treatment to make sure that they've gotten everything. And then especially if they have discharge, we'll often get a vaginal culture. I'm going to go back just a second. Those vaginal cultures are often just vaginal flora, in which case it doesn't need to be treated, but if you see strep or E. coli or things like that, we definitely do treat those. So the next thing I want to talk a little bit about is birth control pills and bone health. So here the premise is that teens are really young, and so we should use low or very low dose OCPs, because that's going to be what's best for them. And the reality is that using 10 or 20 microgram ethinyl estradiol pills can actually prevent appropriate bone accrual, and so we really want to be thoughtful. So Bone mass is attained early in life, and it's the most important modifiable determinant of lifelong skeletal health. Every 10% increase in bone mass during adolescence potentially reduces fracture risk by 50%. So we do want to be really thoughtful as we're making decisions for these teenagers. Approximately 40% of that bone mass is going to be accrued during adolescence, and by age 19, approximately 95% of peak bone mass has been accrued. And so the kids that I'm seeing are kind of in that critical window, and hormonal status is a major determinant of bone health. We all know that our patients who have eating disorders in their teenage years are much more likely to suffer fractures and issues with their bone health later in life because they're missing that kind of estrogen that is crucial to lay down bone. So birth control pills remain the most popular method among adolescents, but they suppress endogenous estrogen production and inhibit hepatic synthesis of IGF-1, which is a potent bone anabolic agent. When we're not on a COC, our mean serum estradiol is about 120 picograms per milliliter. When we're on a 30 microgram pill, it goes down to about 44, and on a 20 pill, it goes even lower, 41 or lower picograms per mil. We don't actually see this change in adults. So for those of you who are prescribing birth control pills for adult patients, this bone health stuff actually doesn't, you can just put this in your back pocket for only your teenage patients. We do know that prospective studies have demonstrated that adolescents who are on 30 to 35 microgram pills do gain bone mineral density at lower rates than non-users, but they are still gaining. But in patients who are on 20 or 10 microgram pills, we see significantly lower accrual rates. We don't really have data on the patch or the ring, so I can't tell you a lot about that because they haven't done specific bone mineral density studies with those methods. And we don't really know what these studies mean for long-term fracture risk, which is the only metric that truly matters, but it is something to be thoughtful of as we're making decisions in our clinical practice. I do want to say a quick word about DEPO. DEPO has a black box warning that advises providers about the negative effects on bone health in adolescents who may not have achieved peak bone mass yet. There is a population-based study that showed an increased risk of fracture and another retrospective study that compared fracture risk to non-users. But the users actually had a higher fracture risk before ever starting on the medicine, so it's unclear kind of how we should interpret that study because it seems like there were probably some confounders that weren't accounted for. There was a more recent study that looked at 309,000 patients using DEPO, and there was an increased fracture risk in those who had used DEPO within the past 2 years or used it for more than 2 years total, but it was not overall increased in patients with past use. Other long-acting reversible methods don't have impacts on bone health, and so it's not that we should bar our patients from using DEPO in their teenage years or bar them from using it for more than 2 years. We just need to have a really good conversation with them, and if this is the method they continue to decide to use, make sure that we're supporting their bone health with things like calcium, vitamin D, weight-bearing exercise, all of those kinds of things. Great. I can probably talk a little bit slower because I still have 20 minutes. The next thing I want to talk about is teens and endometriosis. So the premise here is that one must menstruate for many years before they're able to develop endometriosis. Also, teens are just whiny and they don't really want to go to school. So when they say that their period is causing them pain and they have to stay home, they're probably just faking it. The reality is that at least 2/3 of patients with persistent pain on hormone medication will in fact have endometriosis diagnosed at the time of surgery. Our patients who have a first-degree relative, so parent, sibling, grandparent on either side, mom or dad's side, or a maternal or paternal aunt who have endometriosis have a relative increased risk of 7 to 10-fold. So pretty significant to make sure that we're thinking about that when we're taking family histories. So I always like to share this slide because this is from my textbook. I didn't train. It's getting longer and longer ago, it turns out, but it wasn't that long ago that I trained. But this is the main gynecology textbook that we used in my residency, and these are direct quotes. So the typical patient with endometriosis is in her mid-30s, is nulliparous and involuntarily infertile and has symptoms of secondary dysmenorrhea and pelvic pain. Endometriosis in teenagers should be investigated for obstructive reproductive tract anomalies or abnormalities that increase the amount of retrograde menstruation, which is true. We do know that virtually 100% of patients who have an obstructive anomaly will have endometriosis, but around 95% of that endometriosis will resolve after we've corrected the obstruction. And then the disease is usually first diagnosed in women during their mid to late 20s. We know that none of these things are true anymore. We see a very high incidence of endometriosis in the teenage population. And these patients often have a pretty classic story. They're missing school for their period pain at least one day a month. They have tried all the things, all the pain medicines, and they really feel like, you ask them to rate their pain at its worst during their period, and they will say that their pain is 8 to 10 out of 10. They're often having nausea, maybe associated vomiting. Some of them will have said that they had syncope from pain, just very kind of dramatic presentations. And they have maybe tried birth control pills, maybe not, but we do know that in patients who have done appropriate, so we consider that kind of continuous use, birth control pills or an IUD or Depo or whatever, for 3 to 6 months, at the time of laparoscopy, 75 to 95% of them will have endometriosis found when we go to look. So endometriosis is tricky in teenagers, and if you're not used to looking for it, it can be missed. It's much more superficial. We don't see that deep infiltrating endometriosis that we tend to see in older adult patients. It's very uncommon for our patients to have endometriomas, but they have these kind of small white, red, yellow, clear lesions that sit like dewdrops on the peritoneum. So when I describe it to my patients, I say, imagine a blade of grass with a dewdrop on it. That's kind of what your endometriosis typically looks like when we see it. And so we can't see it on imaging, we can't see it on ultrasound, we can't see it on an MRI. So despite the fact that in our adult patients we're getting much better at seeing endometriosis, we just can't see it in our teenagers. We also know that eventually there might be a blood test or a saliva test or something. There actually is a newer test that just came out in Europe that can identify some biomarkers that are associated with endometriosis, but none of those testing modalities are tested or approved in teenagers yet. So down in the bottom right corner, you can see some kind of more of those classic powder burn lesions. We probably all remember that from medical school. We sometimes see that in teenagers, but it's pretty uncommon. And so if you don't know what you're looking for, it's really easy to miss this. We estimate that 25 to 38.3% of adolescents with chronic pelvic pain actually do, in fact, have endometriosis. We talked about kind of their response to medicines, and even in our teenage population, the diagnosis occurs an average of 6.7 years after symptom onset. So if you can imagine, kids who start menstruating at, say, 12.3 is the average age of menstruation or menarche here in the United States. If you add 6.7 years to that, we get to 18. That's a lot of years of school and missed class days and all of those things, and just missed life being a teenager. And so we really want to try to catch that if we can. All right, this is my last slide, or my last set of slides, my last pearl for you guys. So the last is teens and IUDs, and this is like a thing that I love to talk about. So, and the premise is that those who have not had a baby, or sometimes those who haven't had intercourse or haven't used a tampon, can't have an IUD. And the reality is that most individuals who are menstruating are, in fact, candidates for IUDs. So some background here. Product labeling and package inserts originally came out saying that only patients who were parous could have an IUD placed. And so that was kind of our initial nope, if you haven't had a baby, you can't have an IUD. And then the copper IUD changed its labeling to say that we could, in fact, use it in nulliparous patients. And now all of the IUDs have kind of followed suit. we know that there's a lot of bad press. So I still have parents who are in my office who say, I don't know, I've heard a lot of bad things about IUDs, and that really all comes from the Delcon Shield. And so the Delcon Shield is labeled up here in this picture, but it's the one that looks like a little parasite or a little bug. And it had some problems with it that led to a lot of infections. Part of it was related to the strings that were on the IUD. Our strings now are double monofilament strings, so just 2 monofilament strings that come off of the IUD. In the Delcon Shield, it was actually a braided string that came off of the IUD, and that served as like a little ladder for the bacteria to climb up and led to significant rates of endometritis as well as pelvic inflammatory disease, which was bad, obviously, and that was pulled from the market. But our new IUDs aren't like that, and the rates of infection are very, very low with the IUD. There's also culture concerns. I have lots of patients who come to my office, and parents are like, well, if she gets an IUD, she won't be a virgin anymore. We talk about how, virginity involves intercourse. There's no intercourse involved in placing an IUD, obviously, and try to kind of just quell some fears and misconceptions around that. And then this is really big and has actually gotten even bigger since I originally made these slides about social media and online reviews. So there's actually a trend right now on TikTok. I don't know how many of you follow the TikTok news, but of women filming their faces while they're getting their IUD placed and then posting those kind of reaction videos on TikTok. And I think it's really difficult. There's a lot of kind of just in general bad press about like doctors who take care of women torture women. We wouldn't like do this otherwise. Like we lie about how IUDs are placed. And the reality is that the placement of IUDs is really individual. Like the experience everyone has, even from IUD to IUD, is very individualized. And it's hard to tell patients exactly what they're going to experience. I put in a lot of IUDs, many a week. Some awake, some with Valium, some under complete anesthesia, but I can never exactly predict how someone's gonna do. I had a 10-year-old come into my office one day, and she is like, I'm here, and I want an IUD. Okay, well, let's talk about your periods. No, you don't understand. I wore a dress today, and I am getting an IUD. I'm not going home without one. I go, cool, it's great. Let's talk about your periods, and then we can do that. And she laid there like a champ. She laid there like someone who's had 6 babies vaginally and is getting their IUD placed right after their 6th baby was born. Didn't flinch at all. And then I have patients who can't tolerate getting it placed awake, and we need to do it under anesthesia. And so I can tell you kind of the sensations you might feel, but it's really hard for me to tell you exactly what you're going to experience. So here is a table that shows all of the IUDs in the United States. There are 5 available. The Mirena and the Liletta are equivalent, just made by different manufacturers. The Liletta is kind of the quote-unquote generic version that was made after Mirena came off patent. Kyleena and Skyla are both made by the maker of Mirena, and then the Paragard is the copper IUD. So the only IUDs that are approved to treat menstrual complaints, essentially heavy bleeding, dysmenorrhea, those kinds of things, are the Mirena and the Liletta. They are good for 8 years, although the Liletta, I think, doesn't officially have the 8-year. It has still the 7-year labeling, but it's the same as the Mirena, so we consider them equivalent, 8 years, and actually currently being looked at for 10 years. I do talk with my patients that if they are using an IUD for menstrual management, heavy periods, painful periods, etc., we may need to change it a little closer to the 5-year mark. The amount of progestin that is released daily between years 5 and 6 actually drops off pretty significantly, and so it may no longer be enough to kind of achieve that amenorrhea or lightening of the bleeding and management of pain. But some patients still continue to do really well into years 6, 7, and even 8. So we kind of just play it by ear for that. The copper IUD in many countries is labeled for up to 12 years. Here in the United States, it's only labeled for 10, but we do use it off-label up to 12 years. I typically talk with my teenagers because, again, most of them may not even be using this for contraception at all, but if they are using it for contraception, they often have a period complaint as well. So the Paragard IUD, it's important to counsel patients and let them know that there is a possibility that their periods can get heavier and more painful. So in general, my teenage patients kind of tend to shy away from it. The Skyla and the Kyleena are often marketed towards teenage patients or nulliparous patients because they're smaller. As you can see up here, they are not very much smaller. They're 2 millimeters by 4 millimeters smaller, which is really not clinically significant, and they don't do that good job of managing bleeding. So I often see patients who've had Kyleenas placed, because almost no one's using Skylas because they're only good for 3 years. That's like really often to have to come in and get your IUD changed since it's no fun. The Kyleena is good for 5, but we often have to change that Kyleena out because they're still not getting adequate menstrual suppression or menstrual management of their complaints. And so I really encourage you, if you're taking care of a teenager who has, and you're someone who places IUDs, and they are having period complaints, really talking with them about a Mirena or Liletta. There are some concerns. So ACOG and AAP both recommend this as first-line contraception for our teens. We do say that in nulliparous patients, the copper IUD has a slight increased risk of expulsion. People are concerned in general, like, oh, well, what about infection risk? The risk for PID is highest in the first 3 weeks after placement, and it's really associated with high-risk sexual behavior, not the IUD itself. So patients who are engaging with, multiple partners, not using barrier methods, things like that, they're more likely to get PID, and it's not really because they have an IUD, it's because they're doing those high-risk things. And most patients who develop PID with an IUD will actually have been infected at the time of placement, like the cervical infection occurred before we placed it, and it just is manifesting after placement. So that's why we typically co-test everyone for gonorrhea and chlamydia at the same time that we place the IUD. Tubal infertility is associated with a history of PID, but not current or previous IUD use. So if you've had PID, you could certainly have tubal infertility, but the IUD by itself does not increase the risk of tubal infertility, which is kind of a myth that has perpetuated itself around the world and around social media. I have a lot of patients who go, well, I want to have a baby someday, so I can't have an IUD. No, you totally can. It's actually a great way to, keep you not pregnant until you want to be. And then once placed, it has a protective effect by thickening the cervical mucus and decreasing menstrual blood loss. There's a rapid return to fertility, with 86.1% of users of the Mirena or the levonorgestrel IUD and 88% of copper users becoming pregnant within 12 months. So really, really fast return of fertility for these patients. All right, I have a couple of minutes left before my talk is over. I'd be happy to take any questions about anything I talked about or any other burning pediatric gynecology questions you might have.
So if you could clarify at the beginning when you talked about adolescent birth control pills and its effect on bone density. So clarify again, there's a negative effect, but it's less or it's more with a lower dose of estrogen? Yeah,
I didn't do the best job with that. So we typically see patients being prescribed 10 and 20 microgram pills, and we know that those pills specifically affect the accrual of bone mass. And so we really want to try to start teens on 30 and 35 microgram pills because, well, they aren't accruing bone as quickly as if they were on nothing. They're accruing bone much better than if they were on a 10 or 20 microgram pill. We also know in general that teens do better with 30 and 35 microgram pills. They have a lot less breakthrough bleeding. They have a lot less just kind of symptoms when they take those 30 and 35 microgram pills.
Is the 30 or 35 still a negative?
It's still less than if they were on nothing, but it's a lot more than if they were on a 10 or 20.
Do we need to be telling them each time that this affects their bone density negatively?
So if I have patients on 10 and 20, I really try to make sure they're doing calcium, vitamin D, getting good weight-bearing exercise. 30 and 35 doesn't seem to have as much of an impact, and so I don't counsel them as strongly because if we're controlling their symptoms or we're preventing pregnancy or whatever we're doing, I think there the benefits outweigh the risks.
Questions. One is, so the hormonal IUD, that doesn't have any effect on bone density?
None.
When the
Yep.
depot does, okay.
Yep.
So Does that make sense, or?
Yeah, so Depo is systemic, whereas the hormonal IUD is local.
It's local,
Mhm.
okay.
So,
All right. Now, the other question is, I wanted to ask this question to the lady, or the first lady with the sexual assaults. When a parent comes in and says, oh, my husband, had the kids for the weekend, now she has a vaginal itch or a vaginal discomfort. I mean, I don't want to traumatize the child with any kind of extensive exam. So what would you suggest we do when someone comes in with a complaint like that?
yeah, that's a really common thing that I see. I see it every couple of weeks, I think, and these custody battles can be really difficult. And so typically I talk about, I'll do an just external exam. If I see discharge, I will culture it, but otherwise I'll just talk about doing hygiene measures. And we see a lot that dads, when they have little girls, are concerned that they're going to be accused of exactly these things, and so they may not help them with hygiene as much. And so talking about hygiene changes, things that the little girl can do by herself when she's at her parents' house, those kinds of things can be helpful. And then if there's ongoing concerns, then you can always, if the child discloses something, or if there's discharge that's not getting better, or you have a positive culture, then getting the Children's Justice Centers or Safe and Healthy Families at the Children's Hospital involved is helpful. All right, thank you so much for your time. I really appreciate it.